My name's Dan Hrushka. I'm the director of Annie's Thesis, and I'd also like to just say, you all know her very well, so you know how motivated she is, but it was such a treat to see her move from her passion for maternal and child health and midwifery to formulating a project, to getting funding for it, and then writing it up and doing what I think was a very nice thesis. So with that, I'll just leave it to you to present.
Thank you. I'm so glad you all could come out here today. I'm really excited to share with you the work that I've done in global midwifery. And yeah, I would just like to start by thanking Dr. Hrushka and Dr. Maupin for being incredible directors and not only helping me with my project, but also getting me to some of the different countries that I was able to go to. So it's been really special. As we get going, I just wanted to go through and provide a bit of an agenda for what we'll be going over. This might look a bit like the scientific method, which is intentional. I'm going to be doing an overview on maternal health care and the Millennium Development Goals, looking at my research question, exploring some of the settings that I was able to visit to do the research. I'll explain my quantitative and qualitative methodology, and then go over my results, giving some conclusions and future directions for study. Welcome. So in 1990, the United Nations set a Millennium Development Goal to reduce global maternal mortality 75% by 2015. As of 2013, which is the most recent data we have, maternal mortality has only been reduced by about 45%. While it's a significant reduction, there's still a lot of progress to be made. So the WHO has also recommended that we need to increase the skilled birth attendants who are able to be present for women during the pregnancy and delivery stages of birth. That number has increased a lot, from 59% to 71% of births attended by a skilled birth attendant. And those are defined by the WHO as doctors, nurses, or midwives who can provide this care. So the WHO, the World Health Organization, does recommend that proven healthcare interventions can prevent or manage these complications that are having to do with maternal mortality, including antenatal care in pregnancy, skilled care during childbirth, and care and support in the weeks after childbirth. What this means is that a lot of the factors that contribute to maternal mortality are those that with some simple medical facilities and early intervention can definitely be mitigated. And some of the big organizations such as the WHO, UNFPA, and the World Bank all say that skilled midwives working in first level facilities can meet these global maternal health care needs, because midwifery is able to provide a perspective that works on the prevention and then can transfer care to more skilled doctors and obstetricians in needs of intervention. So what is a midwife? In the US, we have some interesting perspectives, and so I just want to kind of set some groundwork as we go. The International Confederation of Midwives says that midwives must be educated according to national standards, registered and licensed with the term of midwife, and competent in the practice of midwifery. The WHO uses a similar definition, but acknowledges that in different contexts there might be different interpretations about what a midwife is and what they do. And also it's important for all midwifery practice to use evidence-based medical work and really have their practice be based on the research that is available. There's been some critiques, though, of this fine delineation between different types of birth attendants. For example, the WHO, they clarify that traditional birth attendants, or TBAs, are those individuals who their skill has been based more on cultural knowledge and apprenticeship rather than any formal medical training. Similarly, community skilled birth attendants might have a little bit more medical training, but have not completed a specific midwifery program. So in a lot of the international development work, they recommend that more funding and emphasis into these two roles is not actually as effective in reducing maternal mortality. Instead, they present that licensed midwives through a direct entry program or nurse midwives are able to provide the best, most comprehensive care. But some anthropologists have had critiques of these definitions, saying that defining birth and midwifery according to such a specific lens that comes from a lot of our Western ideas about the biomedical models of care, that might not actually be interpreted well in each different cultural context. And it neglects what different cultures see as the value and the meaning of birth. So it's important to be careful when defining what the midwives are in these cases. So I just wanted to set some background on some of the discussion about what midwifery is, which really led to my own interest in discovering the role of a midwife. So my two research questions, which I'll be going in today, is how do midwives across diverse settings define their role and scope of practice? And furthermore, what barriers do midwives identify in giving the best care to women? With a really generous grant from the Circumnavigators Club, I was funded to travel to 6 countries this past summer in 13 weeks. I met midwives in a variety of settings, some of whom might be defined as traditional birth attendants by organizations such as the WHO, but as these were the women who were providing maternal and prenatal care to women in their communities, I did identify them as midwives for the sake of this project. I had interviews with them and also did an activity to try to understand what is their scope of practice. So in choosing my countries, I chose 3 which are higher GDP, more industrialized countries, and 3 which are more low GDP, developing countries, just to understand how midwifery is different in these countries and what are the approaches that these different professions have used. So in the Netherlands, I interviewed 8 midwives. Here the program is more direct entry. So the midwives, they attend specific midwifery training. And a big part of the Dutch culture is to have home births and only go to the hospital if there's if there's a higher risk situation or a patient's desire to use painkillers. In Sweden, midwives have been registered and trained for 200 years, which is something they're very proud of. They're all nurse midwives and practice in the hospital, which is a pretty big contrast to the way the Dutch view birth. And lastly, in Australia, there's a mixture of nurse midwifery education and direct entry education, where a lot of midwives practice in the public health hospital or birth centers, and the public system provides more continuity of care from the midwives, whereas the private system is more obstetric-led, and the midwives kind of serve as secondary roles to the obstetrician's care. So next, in some of the lower GDP countries, I visited Rwanda, which since the late 1990s has had a more formal, trained, registered midwifery program. They have a 3-year advanced program and a 5-year bachelor's direct entry program, and the midwives there, they work in hospitals. Bangladesh is a very interesting case study because it has a variety of individuals who are categorized into different midwifery terms, such as TBAs, CSBAs, as we encountered earlier, nurse midwives who are trained sometimes in other countries. But as of this past year, they have graduated their first cohort of specific direct entry midwives. And these are all motions that have been made in order to meet some of these Millennium Development Goals. Many of these midwives work in hospitals and health centers. And lastly, in Guatemala, I interviewed 6 midwives who would be regarded as TBAs by the World Health Organization. In Guatemala, there is no formally recognized profession of midwifery. However, midwives are able to be licensed through the government, who does provide some monthly training programs for these midwives. And they mostly focus in rural home birth unless there's complications that arise, which they can help women go into the more urban hospitals. So these are just a scope of the participants which I interviewed, both through a pile sort activity and through open-ended interviews. So to get at the question of what is a midwife's scope of practice, what I did was I chose 17 different services that a midwife could provide. And these were found from the International Confederation of Midwives, their curricula on what are important skills for midwives to provide. So I chose those that covered a variety of aspects such as education, clinical work, and community health work. What I did was that I was able to, during the interviews, I asked the women to look at all the services, to first classify those which are in their scope of practice and out of their scope of practice. And then in a secondary stage, I asked them to scope those within the practice into core or most essential duties and secondary duties for the midwife to provide. Just trying to kind of get at what are the duties that midwives identify as most core to their own practice. I then went through and was able to analyze these through just looking at the percentages of midwives who would identify a certain service as core, secondary, or periphery, and also a method by examining how pairs of individuals agreed on this ranking system of the services. Another way that I answered the questions of the midwife's role and barriers was by doing open-ended interviews. I spent time with the women in some countries in English and other countries through translators, asking how they define what a midwife is and does, and what are the barriers that they are seeing in giving the best care to women. I then went through and analyzed this according to thematic coding. So I looked at the interviews and was able to try to draw connections as to common themes that the midwives were bringing up to flesh out what were some of the responses and what did they have in common across these countries. So in analyzing the pile sort activity, we broke them up into 3 categories: core, secondary, and out of scope. Those core activities were identified by over 75% of the midwives as central to their practice. And I think here we can see there's kind of about 3 different categories. There's being able to manage delivery and refer when necessary, such as vaginal exams and refer to doctor. There's responding to emergency care for newborns and mothers who are bleeding and providing education both prenatally and through breastfeeding. Now the next category was identified as 25% to 75% as core, and most of these activities kind of fell into the general within the scope of practice. So having to do with family planning, assisting with chores, HIV testing, negotiating care with family members. In some cultures, women don't have too much autonomy in their role as a patient, and so it's up to the husband or the mother-in-law to basically decide when they get care and what kind of care they will receive. Additional services included performing episiotomies, providing community health care, and educating in human rights. And then lastly, the practices which were most commonly referred to as out of scope or under 25% referred to as core were a little bit more high-level skills, such as vacuum extractions, induction with Pitocin, external version for breech, and then gynecological care, which many midwives said we can do, we're just really busy with the young women. So when I did this analysis, I also then grouped the high and low GDP countries. I assumed that there might be some difference in how these countries ranked the services according to those 2 categories, and I actually found that the only statistically significant difference was in family planning, where 93% of the midwives in the lower GDP country group said that family planning was core, whereas 59% of those in the high GDP group said that it was core. And I would explain this difference by the fact that in the lower GDP areas, midwives represent a lot of the health care that women are able to receive, and there have been a lot more programs directed at providing better fertility and birth control options for women in developing countries. But I think that would be something that would be interesting to explore a little bit further. Another way that I looked at this data was by evaluating how pairs of people responded. So I would say, how did a person from Sweden rank these, and then how did a person from Bangladesh rank these, and look at their level of agreement. Overall, average agreement between all random pairs was 56%. But there were 4 different countries who their agreement within the country differed than agreement outside the country. So that was Australia, Bangladesh, and Rwanda. Pairs within the country had higher agreement than any random pair. And I think a lot of this has to do with Bangladesh and Rwanda's programs are a little bit newer and they have more strict guidelines. I'm honestly not sure why Australia was that way, except perhaps there would maybe be more definitions in the public system as to what a midwife can provide. A very, very surprising result was here in Sweden that there was actually less agreement between Swedish midwives than between any set of midwives. So this surprised me because midwifery has been professionalized for 200 years there. But I also think that midwives really provide comprehensive care in many areas. During my time there, I interviewed midwives who work specifically in family planning in clinic, who have PhDs and work in academic positions. And so either my sample was small or it was just representative of the diversity of experience that Swedish midwives have. So looking then at some of the more qualitative work, which I think is really exciting because this is an opportunity for me to kind of showcase or to present the voices of the women I talk to you in the form of some specific quotations that they told me. When looking at some of the themes and how midwives define their role, 4 main ones stuck out, which is that midwives provide support, they counsel women, they are the specialists in normal delivery, and midwives are educated. So this first one, midwives supporting mothers. I also want to clarify that for the sake of the pile sort, I used 56 respondents, whereas for the qualitative data, I looked at 30 respondents, 5 from each country, just because it was a little bit more feasible to evaluate that much data. So midwife support has a lot to do with the relationship of the midwife with the woman. The fact that a midwife perceives a woman as an agent central to her own pregnancy and birth experience and comes alongside her to support. I think this is really special too because the Greek word for midwife means to be with woman, which kind of shows what that relationship looks like. So for example, in Rwanda, a midwife said, "If I see the mom who is in labor, I think this mother needs support psychologically. So I help her to give her some support and to give her encouragement." And in Netherlands, midwives act as a coach to enable women to deliver, to stand beside them as they deliver. The midwife does not deliver. And I think this is really interesting because coming from an American context, we tend to see somebody needs to deliver the baby who isn't the mom. Is it a doctor? Is it a nurse? But this Dutch midwife is saying, no, the woman delivers her own baby and we are there with her to help manage any situations that are going on, but to provide support. Next is that midwives counsel. And the way I distinguish these is the support has to do with the relationship with the woman, and counseling has to do with education and training in areas such as pregnancy, birth, and family planning. In Guatemala, the midwife said that a midwife also talks to them about family planning so that they don't suffer that much, and so that babies don't suffer that much. This is highly important in countries where family planning is very stigmatized, and there's a lot of misunderstanding about the ways that people can use it and if it is okay to use it. And so the midwife said that their role was to connect and counsel women because they also understand the background which they come from. And in Australia, so it's a lot of emotional guidance and then also education after they've had their babies about mothering. That a midwife is able to provide guidance and counseling even after the baby is born, that encapsulates a little bit broader scope of the mother and baby's experience. Midwives said that they are the guardians of normal delivery and know when to refer in cases of complications such as require more intervention or obstetric care. So a midwife in Bangladesh said, the midwife is an independent practitioner of normal delivery. She is able to refer the complicated cases. And a Swedish midwife said something super similar. She assists women in pregnancy, labor, and birth. If you simplify it, she has two things she has to focus on. And that is to see that the process is as normal as possible and take action when it deviates from normal. So I think it's so interesting that in such diverse contexts, the midwives really understand where they engage in this space of normal low-risk delivery and when it's appropriate to refer. And lastly, for the role, midwives are trained. Midwives in these three countries particularly, when asked, what is your role? They said, we are trained, we are educated. And I think a lot of this has to do, Rwanda and Bangladesh have newer training programs. That's key to this new definition of what a midwife is. And Sweden, 200 years, as I mentioned, they're very proud of this longevity. So in Rwanda, they have been upgraded to the formal training. The person who is called the midwife in Rwanda now, she is the one who is following the standards, kind of indicating the shift in how midwives engage in the community and are trained. And then for Sweden, she is well educated because she is also a nurse. She is a nurse midwife. So even here, we're seeing the difference in the types of training. Rwanda tends to be more direct entry, and Sweden is nurse midwifery. But that education and training is such a central component to this role of the midwife. And then going into the next category, what barriers do midwives identify? There's quite a few more varieties here. So for the sake of this presentation, I'm only going to get into the first three. But these included collaboration with medical staff, the way that midwifery care does or does not fit into biomedical models of care, understaffing, lack of education, issues in funding, and preventative policies and procedures that make it difficult for a midwife to practice, specifically for a midwife to give the best care to women. So collaboration and doctors' respect varies across the different cultures. In Australia, they explain that in other hospitals, it can be very obstetric-led. There can be a real divide between obstetricians and midwives. So that then becomes a barrier for what midwives can do for the woman because it stops us from allowing a normal birth or the normality of birth to be number one. Many midwives explain that if they're able to manage and to support the normal birth and then refer in the complicated cases, this can be a seamless transition when it actually makes sense. But sometimes if there's obstetricians working alongside the midwife, the hierarchy of the medical system can kind of come in and make it difficult for the doctors to actually respect and to give credibility to the midwife's work. So I asked 20 out of the 30, which is kind of happened this way, that I asked them, do you feel that you are respected by doctors? And to explain that a bit. 40% said they often do get respect, which included Bangladesh and Australia. 35% said they sometimes get respect, which was Netherlands and Sweden. And then 25% of these midwives said they do not get respect, and these were every single midwife from Guatemala. Because of the lack of recognizing midwifery as a profession and having the standard education registration process, there's a little bit more conflict if a midwife were to bring a woman into the hospital in cases of complication. And there can also be a bit more of cultural class with the indigenous women in the more like the Spanish-speaking hospitals. So I thought that was really important and can also guide some future work in these areas. And then midwife models clashed with the biomedical model. As I was explaining just a bit before, many midwives say they feel like birth has been a bit industrialized and they're not able to provide continuity of care that recognizes the woman as the central agent of her birth. In Sweden, a midwife said, because when you are a midwife, you like to be a midwife. You want to be there, you need time. You have to know each other and things. It's not industry. It's been treated as a delivery industry. It's like that. It's not good. So there are several factors that the model of care, the more biomedical model, makes it difficult for midwives to provide care to women. And lastly, that understaffing is a problem. So in actually every single country, well, that's not every single midwife, during most of the interviews, midwives did express that there's problems with staffing. In Netherlands and Sweden, it might be retirement. In the underdeveloped countries, or the developing countries, it's the idea that we're still trying to increase the number of birth attendants who can take care of women, and there's never enough. So I think this quote by midwife Naranja really sums up a lot of the feeling that I was hearing as I was listening to these stories. The shift is here. We have many mothers, but the midwives are not enough. We are not enough. It's overloaded. Imagine you can have a shift of 3 midwives and 8 mothers. Yes, to follow them is very difficult. Imagine overloaded. So there was many stories and many experiences that I was able to just have the privilege to hear during these travels, and I'm really glad to give you a glimpse of some of the words that these midwives were able to say. And I think having such a broad scope of my research settings makes it difficult to come away and know this is midwifery in this situation. In fact, I've come away knowing it's so nuanced, and there's general themes that all these diverse countries are exploring, but each story and each context is really individual. So as I've been tempted to conclude what this work has been, I think that really an important part is that midwives agree on elements of their scope of practice. The fact that there wasn't a huge difference between high and low GDP countries in the way that they ranked the 17 services that I chose to ask them about shows that there is some consensus among midwives across different contexts. That midwifery is a relational role toward and with women in the context of low risk and normal birth, and what that does to establish a woman-centered experience of pregnancy and birth is something that's very unique to midwifery. And as far as barriers, that medically industrialized healthcare systems can present barriers to providing midwifery care, especially in context of the biomedical model, where doctors might perceive pregnancy and birth as a time of crisis instead of a more natural life event that just needs to be guided and guarded well. So as far as future directions, I know I'm very excited about this field, and I hope to explore some of these areas in my own work, or just to see them be developed in general. But I'm looking to explore how midwifery can be professionalized to meet cultural specific needs and values that really asks what are these contexts, what does birth mean, and have a lot of the development be done in those ways. To investigate strategies for collaboration between doctors and midwives. One thing, a follow-up question that I wasn't able to go into here, but I would ask, are you respected by doctors? Do you collaborate well? Yes or no? Okay, what do you think would help that? And so that's data that I actually have that I'm looking forward to hopefully actually exploring a little more and just seeing strategies for how this can be improved. And that lastly, as we're looking at huge global development and major movements to reduce maternal mortality, it's important to integrate midwifery care and training into the maternal health care system in ways that serve the women's needs rather than fitting into a biomedical model that we externally place on the way that birth should be or is best to be, but rather centralizes the woman and her family and her specific needs as the most important. So I hope to be able to have the opportunity to dive into some more of this with my work already and just in the future. I am really privileged by this opportunity and really want to thank you all for being here today. So that's it.